I'm talking about this actually. And so I threw together a couple slides, but just wanted to briefly chat about expedited partner therapy. So if we're all sitting together in a room like we used to before the COVID pandemic, I'd ask folks to raise their hand if they've ever done EPT. But maybe if you have done EPT, I'd be curious, maybe just throw it into the chat there, just to get a sense of if this is something on people's radar, if they've done it before. I will admit that I do it here and there, and we'll talk a little bit more about at least my approach to this as well. Just to make sure we're all on the same page, just want to throw out the definition of EPT, right? It's treating sex partners of patients specifically diagnosed with gonorrhea and chlamydia. So we're only talking about gonorrhea and chlamydia by giving them prescriptions or medications to the patient, to their partner, without actually seeing them first. And so I think as a provider, right, this makes me a little bit nervous, and it should. And I just want to acknowledge that. But it is an important and well-validated and studied effective public health intervention. And we'll kind of talk through some of this as well. I did something on these slides that I don't usually do, and we can send these around, but I included a lot of text. And I don't usually do that, but I felt like it was important for EPT because I really wanted everyone to see how the recommendations and guidelines were worded. So the first thing I just want to let everyone know is that EPT is permissible and allowable by law here in the state of Rhode Island, both through state law, Department of Health regulations. You can do expedited partner therapy, meaning prescribe a prescription specifically for gonorrhea, chlamydia, without seeing the patient. So it's permissible. And you can see here that there's a couple states where it's a little bit unclear, but in general, you can do it throughout the US. And the first study here, I just wanted to show, this was a study from 2005 from some of our colleagues at Washington State, Dr. Matt Golden and King Holmes, who are really heavyweights in the field. But I just wanted to show basically the way that they did these studies looking at EPT, right, is they gave, they took a bunch of people, 1,000 people, who had gonorrhea, chlamydia, and they randomized them into giving their partners EPT versus not. And so they looked at how many folks of those, 1,000 came back with repeat gonorrhea or chlamydia. And what they found was in the group that they gave EPT for gonorrhea, that only 3% of the EPT group compared to the ones that didn't, 11% came back with gonorrhea. So a pretty significant reduction, certainly for gonorrhea. And you can see for chlamydia, it was actually a lot less. So it was 11 versus 13%, 11% in the group that got EPT versus 13 that didn't. And so I just wanted to show these numbers because it kind of, I think, sets the evidence base for EPT and certainly for gonorrhea. And if you look at the recommendations put forth by the CDC, you can see here how it's worded. And it basically says, as we all know, right, the treatment for gonorrhea is monotherapy with IM ceftriaxone. And the CDC guidelines say, use EPT if injection of ceftriaxone is not possible. And then you want to go on and use Cefixime 800 milligrams. And it says here the CDC recommends EPT for heterosexual men and women with gonorrhea. So this is a viable recommendation from the CDC. It's something that, again, I do from time to time. You can see here, though, I know that certainly many of you, including myself, care for a lot of gay, bisexual men who have sex with men. You can see that the CDC recommendations here are, they hedge a little bit. In fact, they say that there's shared clinical decision-making regarding EPT for MSM due to the risk of undiagnosed infections, other infections like HIV, and limited data. So this, my primary population generally has been a lot of gay and bisexual men, and this is one reason why I haven't done it as much. That being said, my approach is that, right, if you had options 1 through 100, options 1 through 100 are get that partner in for treatment, get them evaluated by a medical professional. But if for whatever reason that can't happen, then EPT is an option. And again, it's recommended in heterosexual men and women for gonorrhea. And for MSM, it's really, again, that shared decision making. For chlamydia, it's a little bit, the CDC hedges a little bit more. They said you can consider EPT in chlamydia for heterosexual men and women. And then again, for MSM, shared clinical decision making. I'm not going to read through all this. Basically says, though, that you should hand out written educational materials. You can tell that this was probably reviewed by a legal team. So anyway, I just want to actually throw up the text for this. I'll exit out my slides. You're happy to send this around for folks. But again, really should be kind of a more of a last option, a secondary option for folks that won't come in to get. That being said, it is a validated public health intervention. It is in general recommended by state health departments, including the Rhode Island Department of Health. But just wanted to frame it for everyone. I know that people put some of the stuff in chat here. Let's see. Yes, a few people do. Bryant, Rhode Island College, which is great. But something for folks to consider, and it should be included in our arsenal of for STI prevention. It should be there, again, more of a last option, but certainly included. Dr. Bornstein, do you have any thoughts? And I know that Tom Bertrand, you're on the call too. Happy to hear any additional thoughts that you may have. Dr. Bornstein, any thoughts about this?
I'd love for Tom to go first because I certainly have some thoughts about it as well. And this is Tom's area of expertise.
Yeah. So, hi, everybody. Yeah. So this is important legislation that was passed in Rhode Island. I think it's a good way to reach out to partners if providers have a good relationship with the index case and can be supportive. The key here to keep in mind, though, is I know some providers have some hesitancy about doing this. And I do think you should take advantage of Phil's knowledge and others about how to do this and make it happen appropriately. I know, for example, and Phil, please correct me, I'm not a clinician or an expert in this area, but our colleagues who work in community health centers struggle with this from a legal perspective because of there's torts law that applies to health centers where they are not legally able to perform this function. So I know it can be tricky, but to the degree as a provider you can maximize doing it, I think it's a great approach. But Phil or Suzanne, please comment on what I said, because I don't do this on a day-to-day basis, but want to maximize it and support providers. Phil?
Yeah, Tom, I'll add one quick point I think that you mentioned, which is totally key, which it is just so important to get those partners in however you can. Because we see such high rates of reinfection in general, and obviously there can be pretty significant complications, sequelae from untreated gonorrhea chlamydia infection. I mean, I've even done this where I've have a patient in the room and I'm like, just call your partner, and at least if you get on that phone call, you can establish that provider-patient relationship. You can do some documentation, record at least allergies, etc. So again, I do everything I can to at least have a phone conversation with that other partner. And if I can get them on the telephone, I'm like totally comfortable, right, to prescribe the medication and just ask them a few basic questions, past medical history, allergies, et cetera. There are times, though, I have blindly prescribed, a couple doses for the patient in front of me with the intention that they give one of those doses to their partner. But again, I sort of see that in my clinical practice as a secondary option and try to do everything else first. Dr. Bornstein, what are your thoughts?
I agree with you totally. I think, you in college health are uniquely positioned to have these individuals who are in that valley of no longer in a pediatrician's care necessarily, and yet often will have nobody for a decade until something happens. And so I think you're in a unique position to have these individuals that have tremendous trust in you and faith in you. We know that they don't tell their parents and they won't tell their friends, but they'll tell you. So a couple thoughts that came to mind is having been in your prior role is that I have been told partner doesn't have insurance, partner cannot tell their family, there's no way they're going to get, they're not going to do anything, it's not going to happen. And so there are some health equity issues, there are some of the, and Tom can speak to, I know in some of the insurance products in Rhode Island, the student can, let's say it's a fellow student who's the exposed, is the partner, can opt to not have an explanation of benefits sent to the house. But I think that those are, I think the opportunity to have a conversation, have them tested for other concomitant infections and to talk about, what's, at least having, especially with our MSM students, having a conversation about retesting if indicated and, test of cure. So those are things you can't do with somebody you don't see. Just as an aside, in case you were wondering, having done this before, is that, and spoken with our the pharmacist for the state, is that what one would do if it really was that last resort is to write the patient's name and date of birth, obviously, on the prescription, and to write double dose EPT on the script.
Wonderful. Thank you, Dr. Bornstein. And I'll also add in, Tom, fact check me if I'm wrong on this.
Yeah.
But the Department of Health has some very robust partner services that we reach out to partners. And we do that for all cases of HIV and syphilis. There's an overwhelming number of gonorrhea and chlamydia cases, so we just can't do it. But I will say, if you have specific, and this is why it's so important from a provider perspective, just to really get those partners in, because there's just so many cases. So anything you can do to have the patient in front of you, get their partners in, notify their partners, that's really key. If you have specific scenarios or patients where you feel like it's really vital to get the partner in, you can contact us at the Department of Health and we can put someone on it. We can't do that for everyone, of course, but if you have specific scenarios where you really feel like it's important for whatever reason clinically to get a partner in, we can do that. Tom, fact check me or correct me if I'm wrong.
Absolutely. On a case-by-case basis, we're happy to work with any provider who needs assistance with a case in front of them or with a partner being named to get them in or supporting a case. So you just reach out to us. And Phil, I just want to reinforce the importance of this. Well, first, from a patient perspective, chlamydia reinfection rates are extraordinarily high. They range from 20 to 30%. So this is really important, and that your patients know you can get reinfected and it's serious. Some of them think it's like the measles or chickenpox, you won't get it again. But I think it's really important that they know if their partner isn't treated, they'll be back, at the health center, with symptoms. And I think that's a really important message to take home also.
And it's those repeated infections that can cause things like infertility, et cetera. So we definitely want to obviously address that as much as possible.
Absolutely.
So maybe we can open it up for any questions, and even any questions on PrEP. I know that we chatted about PrEP recently. Any questions that have come up about PrEP, expedited partner therapy, STIs in general? Happy to answer any questions. Anne, good morning. How are you?
Good morning, Bill. Great to see you. So I do have a question that has come up a couple of times here for myself and one other provider with a student that was on Truvada for PrEP. And after, months have gone by, the person has broken up with that partner and is interested in the, use it as needed. Could you talk a little bit about that dosing? Because I've had a lot of questions in regards to, is the testing done at the same frequency as if they were on the daily medication? And then, it was so important for them to be on it for a certain number of days before it became effective. And if they're taking it sort of the day before, the day of, and the day after, I feel uncomfortable answering those questions. So I don't know if you could review that, please.
Yeah, absolutely. So great question. So it has been studied, right? So typical PrEP is, one pill once a day, until, indefinitely, or until you don't need it anymore, at which point you can end it. But it has been studied intermittent PrEP. And the other name for intermittent PrEP is 2-1-1 PrEP. And it's called 2-1-1, right? Because that's the dosing. So I like to say 2-1-1 a lot because that kind of alludes to how you actually use it. So who do you think about intermittent PrEP for? So a person that's having sex every week, you probably want to use daily oral PrEP. Or someone that's having, certainly sex every day, maybe once a week, even once every couple weeks, probably still daily oral PrEP just for adherence. Person that's having sex like once a month, person that has significant concerns about taking medication every day, that's when you really want to think about intermittent 2-1-1 PrEP. So how do you use it? How do you counsel folks? The textbook definition of how to use it, and this is endorsed by the CDC. It's part of the CDC recommendations. It's been studied in randomized controlled trials and shown to be just as effective as daily PrEP if you take it as prescribed. So as the name suggests, 2-1-1, it's 2 pills right before sex. So 2 pills, 2 to 24 hours before sex. It's a third pill 24 hours after having sex, and a fourth pill 24 hours after that third pill. So essentially it's over 3 days, right? So let's say, Friday night, right? Friday night, you think you're going to get lucky tonight, have sex. You're going to take 2 pills on Friday. Friday night you have sex. Then Saturday you're taking a pill, and Sunday you're taking a fourth pill. So 2, 1, 1. And so one thing that often comes up, well, what if I have sex on Friday and Saturday? That sometimes happens. So you want to take those last 2 pills. You want to continue taking a daily pill while you're having sex, and then do a pill the day after you have sex and a final pill the day after that. So let's say you have sex Friday, Saturday, Sunday. It's a big weekend, right? So you're going to take 2 pills on Friday. You're going to take a pill on Saturday, a pill on Sunday. You had sex on Sunday. And then you're going to take a pill on Monday and a final pill on Tuesday. Does that make sense? I always think about it at the weekend because that's the most common example. So it is a viable option. I also do it periodically. And again, it's for people, if you're having sex like once a month, if you're having sex, periodically. The other situation I see actually in the university setting is I do see a number of faculty and staff who college professors, and I've had several, who don't have sex during the school year, but have sex, during the summer and on school break. And so what we generally suggest during those times is to start prep, at least a couple of days before going on vacation and higher risk, behavior, continuing it through 1 pill once a day through, a week of vacation, and then continuing it for a couple of days after getting back. So it's kind of like that extended version of 2-1-1. So there's all sorts of ways that you can use it. And what we've seen in our real world experience is that if you take PrEP, it's going to work. Does that answer your question, Ann?
It does. And then what about the testing? So if they're on the intermittent dosing, do you still see them every 3 months? Do you still do the same testing?
Yeah, I generally, sex is like this. I generally see folks every 3 to 4 months. I mean, it's that balance of, well, if you've had a couple sex partners, who you didn't know, it's probably good to come in at 3 months to get tested. If you push it to 4 and 5 months, well, that's probably fine too. But you generally want to stay in that window, probably 3 to 6 months if someone's on intermittent PrEP, where you want to have them come in just to assess how they're using it. Do they need more? Did they start taking it daily? To do STI testing, of course. So 3 to 6 months.
Perfect. Thank you so much.
Thank you. Good question.
Awesome. Thank you, Dr. Chan. I know, just being considerate of time, if there are other questions, we certainly can put them in the chat. I don't know if you plan to stick around a little bit and want to answer in the chat, or I can send them to you afterwards for follow-up. But any other questions, definitely throw them in the chat and we'll make sure you get an answer. But
I'll be on for a little bit longer. And people can always email me as well. I'll throw my email in the chat. People can email myself, Dr. Bornstein, or Tom for any of these questions. And thank you, everyone. Good to see you.
Thanks so much. All right, with that, I'm going to pass it over to Abby Burns, again, one of our senior public health EPIs at RIDOH, and then Dr. Bornstein to go through an Mpox update. Just to confirm, I know we've gone back and forth. You're screen sharing, Dr. Bornstein, or did you need me to pull up your slides?
I'm happy. Whatever's easiest for you, whatever you think is best. Either way.
I'll let you do it just so you can keep the pace going, but happy to step in if you need.
Super. Okay, I'm pulling it up right now, and hopefully my Teams has been a little persnickety today, but let's hope for the best. So, all right. Hopefully, let me know when you can see things.
Yep, we can see the slides.
Wonderful. Okay, so this will be hopefully an opportunity to review Mpox with you, give you a little bit of sense of where we are, a little bit of a sense where you might be in the next couple of months. We don't know exactly, of course, without a crystal ball, and a little bit of a review as well. And Abby Burns is going to present some of the data around what we've seen so far in Rhode Island. So just to remind you, monkeypox is a member of the orthopox virus genus. And so same genus as variola, which is smallpox, and then vaccinia, which is from the smallpox vaccine. And it is a viral zoonotic disease. It is endemic in certain areas and tropical rainforest areas in Central and West Africa. and thought to be maintained in small animals such as a giant pouched rat and squirrels and dormice. I know, strange. And so here's the good news. We've not had any new Mpox cases. And by the way, sometime last year, CDC made the decision, WHO as well, to change the name to Mpox, a little less stigmatizing. And we've not had any cases since February. In spring and summer, we are expecting or anticipating that we might have seen one, we're almost done with spring, might have seen some increased Mpox transmission in Rhode Island. We have not yet, but we've certainly seen it in other parts of the country. You may have received, hopefully you do receive the provider briefings or advisories. If you do not, please let me know in the chat, and we can make sure that we sign you up for the listserv so that you receive the RIDOH provider briefings and advisories. So in a little bit more detail, Chicago has experienced a new cluster of Mpox cases, and that is having us all think that the big spike that we had last summer with a very, very long tail of occasional cases of 1 or 2 cases per week nationally. And now we're having a new cluster in Chicago and a few other parts of the country that we might indeed begin to see a little bubbling up. And so I want to just review a little bit more about Mpox with you, just to give you a little sense. It was first discovered in 1958 in colonies of monkeys that were kept for research. And the first documented human case was in 1970 in the DRC. And we've had occasional outbreaks in endemic areas. And first outbreak in outside of Africa in the US was in 2003. And we do have sporadic cases in some non-endemic areas. They tend to be generally in travelers. There are 2 clades. One clade was formerly called the Central African, is now clade 1, and with a mortality close to 10%. And then clade 2, which was formerly the West African clade, which has a less virulent mortality of about 1%. Incubation period is somewhere 3 to 7 days, with illness duration 2 to 4 weeks. And those of you who have seen a case will know that it is very often this long on someone who has cutaneous rash, where those lesions, just like chickenpox, they're no longer infectious during once that very last lesion has peeled off and it's replaced by new healthy skin. So the development of initial symptoms will mark the beginning of the prodromal period, and what we've seen is fever, just feeling kind of lousy, headaches, body aches. And this fever will last a couple of days. Not everybody gets a rash, but it is quite common. And we also see some lymphadenopathy. So that's been fairly common. So just to give you a sense of what the rash actually looks like, it has a progression with a timeline. So you can see it starts flat as a macule. And by the way, we'll make sure you get a copy of this slide deck, then becomes papular, a little bumpy, then gets a little filled with fluid. It has a little, then we'll go on around the 5th day or so to have some more yellowish, opaque fluid, and we'll develop then that central donut hole, or what we call umbilication. Then the crusting starts. This is when it gets itchy. And that itchiness can last a couple of weeks. And then when that last scab falls off, that person is no longer contagious. And of course, very often there are new lesions appearing while the older lesions are going through their various stages of change. So here's what's common, what's the most common. And several of these slides are taken from the University of Washington slide deck that Abby Burns was so kind to share with me. And you can see here that rash is seen at about 97%, but very often it could be maybe so mild someone doesn't necessarily see it or know about it. And these are from last year's outbreak. You can see about 64% of people with fever. Again, this can be very subjective, and malaise. And then as you go down the list of the most common signs and symptoms, you can see that where it gets really painful for some folks is if some of those lesions are involved in the mucosa of the lining of in the rectum, around the anal area, where tenesmus can be uncomfortable, bleeding can be uncomfortable, and someone may have frank proctitis. We've also seen a few folks with pink eye, conjunctivitis. What is missing from this is oropharyngeal symptoms. You can see that it's not on here, and we have seen people with oropharyngeal lesions in anywhere from 2 to 30% of cases. So here's what some of the oropharyngeal can look like. Can look very discreet. Boy, that can look like a lot of things. I know you all in college health have seen this a million times on that far left, right? Is it mono? Is it, what could that be? Could it be Kawasaki? So it can look like a lot of things. Of course, in the middle one, frankly, purulent tonsillar exudate. Again, that can look like a lot of things, right? And then this is a little more discreet along the beard lining. You can see this is already scabbed. It's got some secondary infection, probably a little bit of staph on the edges there. So this is more of some lesions on the hand, cutaneous lesions, and they can really look sometimes like anything like erythema marginatum. I mean, they really can look like a lot of different things. So taking a careful sexual history is always important. For those of you who are interested, there's a webinar CDC did that was on May 18th. And it's called the Mpox Update. I've put the link on the bottom. It's an hour. It is superb. I'd encourage you to take a look at it if you have some free time. And so here are just some examples. Oops, I missed one. And actually I want to go to, here's a couple of other examples of, they can be really discreet. We know from the outbreak in Chicago that at least half of the folks have been vaccinated with both doses of the Jynneos vaccine. So what we do know is that the Jynneos vaccine won't keep you necessarily from being infected, but it will likely, and we believe it is true that it will likely keep you from being really ill, having a lot of lesions, getting hospitalized, to let you know. Here are some genital lesions you can see, very discreet, and some lesions around the anus as well. So again, can look like a lot of things, and you got to be thinking that a lot of these individuals will have co-infections, so you want to be thinking about testing them for other STIs if you do see them. So we do have an updated process for specimen collection, and I'm going to give you the link on the next slide so you can see the Rhode Island specific collection for our state lab. You can, of course, use any commercial lab you want, but the good news is we have a new Cepheid expert assay at the state lab, and we can get results within a few hours. Now, the bad news is, of course, generally not open on a Saturday or Sunday unless it's an emergency, and in most cases, Mpox would not be. But just letting you know, you don't need to do 2 swabs per lesion anymore. It's 1 swab. And please, please do not unroof. Just rub it vigorously on top of the lesion. And you can let us know on Monday morning that you've got somebody you swabbed. Please be super careful. I know from our lab manager, there were a lot of unlabeled or they weren't labeled correctly this last summer. Not from you guys necessarily, from other providers in the state, but we want you to know about that. And again, regardless of risk, if you think the patient is at risk for Mpox, you want to have them isolate. So here's what I promised. Over here on the far left is the link for the Rhode Island instructions. Remember, if you're using your own commercial lab, they may have different specimen collection instructions. But if you're going to use our lab, it's pretty basic. You grab that swab, you rub it back and forth 3 times across that lesion. It can be flat like a macule. Macules are contagious. They can shed virus. And then you're going to rotate the swab and rub on the other side of the swab back and forth. And then, like many of you already do all the time, break the swab shaft off into the container and send it off. Ideally, a second lesion site is helpful, but again, only 1 swab for our state lab per lesion, and then send it off to us. And again, instructions are right there. So what do you do if infection prevention control in clinical settings? Pretty straightforward. You want to wear gloves and a mask and PPE ups, and that's not changed. That's not nothing different from last year. And you're more than welcome to take a look at this. This is coming straight from CDC. There's a link there on disinfectants that you can use that are EPA registered. And I'm going to keep going so we can have a little time for COVID. Mpox transmission is really spread predominantly person to person through direct contact. Heavily soiled items could be cause of transmission, but it is really thought to be from physical contact, especially with infectious skin rash. And remember, they can be macular or they can be scabbed until they're completely off and replaced by new skin. They can shed virus. There is placental transfer to fetus. That is possible. And we don't know exactly how Mpox gets spread via respiratory secretions. We do know that 4 days prior to actual symptoms that it is thought people are infectious. So that is something new. And I've given you here some also really nice graphics from CDC on Mpox and safer sex, as well as social gatherings, know before you go. And there's a safer sex info sheet. So those are all great things that you can leave wherever in the waiting room or pass out. So pain is common, as you saw in that slide earlier, that a significant number of people may have anogenital lesions or proctitis or oral lesions. And so pain control is really cornerstone. So over-the-counter reliever, NSAIDs, that should be in, and as well as Tylenol are just fine to use. But sometimes in certain people, they are going to really have some trouble with pain, and if they really need to, you might need to be prescribing something short-term a little bit stronger. If it's really severe proctitis, topical lidocaine, stool softener, sitz baths, the usual things that you might use for a Bartholin's or for someone who's got a fissure. And then for oropharyngeal pain, viscous lidocaine and saltwater gargles can be utilized as well. If someone's really got intractable pain, they might need to be hospitalized, and we have seen that happen. So there is a drug, TPOXX or tecovirimat, that is available for medication for treatment, and who should be considered. We know for many people the illness will be self-limiting and will be unpleasant and a hassle during their isolation periods. But for some, they might have more severe disease. So if someone has an underlying condition, or such as anything that puts them at risk for severely being immunocompromised, pediatric populations, people who are pregnant or breastfeeding, or people that have really advanced eczema. So not mild eczema, but have not well-treated psoriasis, not well-treated eczema. Or if someone has an mpox lesion that is hemorrhagic or really large confluent lesion, might be secondarily infected, ocular infections, or severe pain. So those are all reasons we've seen TPOXX being prescribed. And Abby can talk a little bit about this, but STOMP is the trial used that to try to get some more information on how well STOMP actually, how well tecovirimat actually works for individuals in decreasing the length of the illness and hopefully the number of lesions that people might be continuing to have. So what do you do? How do you counsel somebody while you're waiting for a test result? Please ask them to stay home, separated, not to attend school, work, public settings. If they absolutely cannot avoid, to wear a mask and make sure those lesions are all covered and to avoid physical contact with others. And when they're waiting for test results, they should definitely let their providers, if they have someone else, perhaps they see someone for rheumatoid arthritis or whatever it may be, they need to let them know. And if there's an unavoidable need to seek medical care, they want to make sure that, again, that rash is covered and they're wearing a mask during that visit. Interestingly, pets such as dogs, we have seen or read about some human to dog transmission. So there is some questions about perhaps keeping Sparky with Brendan for a little bit. So what happens if they're positive? Again, isolating, and if they do live with someone else, is to try to wear face mask, avoid physical contact with others, try to use a separate bathroom if possible, and washing their hands frequently. Soap and water and alcohol-based sanitizer does kill mpox. And then things that have been used, towels, sheets, those need to be laundered normally. And again, as you all know, 2 to 4 weeks before that last scab finally goes away. If they don't have a rash, let's say it's rectal pain, urethral pain, they should, again, isolate for 5 days until they are feeling better. Short slide on Jynneos, the live virus vaccine can be administered either subcutaneously or intradermally, and it can be used as post-exposure prophylaxis ideally within about 4 days of being exposed, and in certain individuals, laboratorians, as well as other people at risk, MSM Rhode Islanders, as a pre-exposure prophylaxis. That has been loosened a little bit, so it's a little bit easier. I do want to share with you, and I should probably, Tom, you would have been the perfect person to talk about this. In fact, I'd love for you to chime in about how effective Rhode Island was, if you have a moment.
Oh, yeah. Thanks so much. Congratulations to Rhode Island, everyone part of the monkeypox vaccination initiative. The CDC put out a report a month or two ago about vaccination coverage across the country, and at least amongst the 50 states, Rhode Island ranked #1 for 2-dose coverage. We're beat out by DC and New York City, but they are not states, but we were #1 amongst 2 doses. So, and that's a tribute to everyone's participation, including many of the colleges that had their own clinics and or promoted the efforts. So a really great job all around. And we continue to try to do cleanup clinics now and provide vaccination for people who never got vaccinated. So thank you, Dr. Bornstein, for that opportunity to thank everyone.
Oh, sure. Okay, I'm gonna try to leave a little bit of time for the NPOX. I don't know, Phil, if you would feel comfortable, but I can certainly talk a little bit about racial and ethnic disparities. Is unfortunately no different with this most recent MPOX outbreak in 2020-22. And one of the things we're well aware of, and this is an MMWR to take a look at, is that the overall greater than 1 dose vaccination rates with JYNNEOS were higher among Black and Hispanic males than white males. However, they were not high enough to offset the disproportionate incidence. And so what we saw that the overall incidence among non-Hispanic, Black, or African American, as well as Hispanic males, was much higher than in non-Hispanic white males. So again, more reason to be really having that conversation with our patients about what's going on. I think, Abby, you are up.
Sure. I just wanted to start by, Dr. Bornstein, can you go back to slide 19 for a sec?
I sure will.
Thank you.
Thank you.
Thanks. So I'm the MPOX epidemiologist, and I also just happened to be this morning on the call of the advisory committee on immunization practices, which was talking about MPOX vaccine. And so I know that we have there's been the Chicago cluster, of which over half has been vaccinated. So there's been a lot of questions if a 3rd dose of vaccine is recommended. What are the, what are they looking at? So it's something that CDC is looking at, but currently they're not moving towards a 3rd dose recommendation at this time. So if someone got 2 doses, they don't need a 3rd dose. Additionally, if somebody had MPOX virus or had an MPOX infection, they don't need, there's no recommendation for them to get any doses of vaccine. However, if somebody had 1 dose of vaccine, even if it was over a year ago, it is not too late for them to get a 2nd dose of vaccine. Okay, you can go back to 21. So I wanted to just give a little data update about cases in Rhode Island. So we have had 85 cases in Rhode Island, and that was from June 2022 so we had 84 cases June 2022 to November 2022, and then a big gap, and then we had 1 case in February, and knock on wood, we haven't had any cases since then. July, August, and September were our really big months here. Next slide, please. So just like in most of the country, or in all of the rest of the country, most of our cases were in cisgender men. And if you go to the next slide, they were in cisgender men who have sex with men, gay, bisexual, and other men who have sex with men. And we did not ask people their sexual orientation, but we asked them about their sexual behavior in the 3 weeks prior to illness onset. So we know that 78 of the cases for whom information was available reported sexual or intimate contact with cisgender men in the 3 weeks prior to illness onset. And this mirrors what we're seeing in the rest of the country as well. There have been in the US a good number of cases in cisgender women and in transgender men and transgender women as well, but the greatest proportion is in cisgender men. And if you go to our next slide, the thing that also reflects, so most of our cases were unvaccinated. We have no cases who were fully vaccinated prior to receiving vaccine, prior to having infection with MPOX virus. So 70 of our cases were unvaccinated, were totally unvaccinated. 7 had 1 dose, but it was less than 14 days prior to onset. And so they were like, it takes 14 days to be considered your dose being complete. And 2 doses being fully vaccinated would be 14 days post second dose. And so no one who was 14 days post second dose in Rhode Island so far last year got Mpox. And one of the things that they're seeing in the Chicago cluster is that even among folks who were vaccinated, those who did get disease, there's been no hospitalizations, and they're really seeing better outcomes. So we know that it's preventing severe disease. So this is just a little picture of Mpox in Rhode Island so far. Hopefully we won't have, too much more to update you on in the future, but we are prepared if we do see more cases, and we, as always, look forward to partnering with you. Y'all were great partners last year. And we are happy to test specimens from College Health. And just like last year, give us a call and we'll get that set up for you. The main difference is that you can use viral transport media, and it's just 1 swab per lesion. And also that we're just doing it during the week this time. So thanks as always for your partnership, and Dr. Bornstein and I can take any questions about Mpox if you have any.
A lot, Abby and Dr. Bornstein. Just be aware of time. Any questions that you may have around Mpox, just throw them in the chat. We'll follow up. We do want to make sure we give you the COVID-19 update before we wrap up here. So we'll transition to that. I'll share my screen, and then Dr. Bornstein will kick us off here.
Can you believe it? We're still talking about COVID.
It should be the last big update, hopefully. Fingers
Yeah.
crossed.
We're crossing our fingers for you. All right, this is where we're starting. Is that Julie?
Yes, go ahead.
Okay,
We'll skip the
super.
agenda.
Okay,
We'll
yeah, let's
dive
start there. So just to give you a sense, what's happened since we met you in March is that the public health emergency declaration, the federal, have largely all expired. Obviously, the Rhode Island executive orders have also expired. So what's unchanged is still a public health challenge, especially in long-term care facilities, nursing homes, and for more at risk. And the clinical guidance hasn't changed. Still isolating, and still if exposed, wearing a mask and getting tested. So that's not changed. Will that change? Maybe, but it's not for the time being. And the public health recommendations for infection prevention and control have been updated by CDC for healthcare settings. And COVID-19 nationally remains a reportable illness. What's been updated is there are no more community levels. Remember back in February 2022, we had the community levels for COVID-19. They have gone. And we are now using COVID-19 hospital admission levels instead. And those hospital admission levels have joined the CDC website on something called ResBlends, which is an interactive dashboard that shows COVID with RSV and influenza all together. Will COVID begin to sync with RSV and flu? Who knows? Let's hope. We do know from our modeling team at Brown at the School of Public Health, we are anticipating a wave in September, so no surprise. The other thing to know is that tests and treatments have now joined the normal practice of medicine. Next slide. Surveillance. So just a word about the surveillance. Again, we talked a little bit about there's no more community levels. So how do you know what COVID's doing? How do you know? Is by looking at hospital admission rates. The hospital admission rates will tell hospitals, nursing homes what to do in terms of you see more than 20 hospitalizations in a week's time for COVID. That may be when thinking about instituting their own masking in the facility and thinking about other things they can do to decrease spread in the facility. The other thing to be looking at is we're watching COVID-19 deaths. That's obviously a really late indicator, but if we see a big uptick in deaths, we would be worrying about usefulness of perhaps treatments, or wondering also if that there is some kind of a change in the virus itself that makes it more virulent. So early indicators, we're going to be looking at department visits. So we look at the percent of people that show up in an emergency room in Rhode Island with a respiratory complaint and end up having a COVID diagnosis. So again, the percent of people, anybody who walks into any ED in a participating Rhode Island ED with a respiratory symptom gets diagnosed with COVID, that's going to be a percent that will be an early indicator. And we're also doing really super cool surveillance, wastewater surveillance in at least 8 sites, including corrections, watching to see what happens with COVID. Of course, genomic surveillance will continue to be done here at our state lab. We watch to see, what's new. Right now, we have, of course, XBB, which is one of the great grandbabies of Omicron. And then, of course, we keep an eye on vaccination coverage, safety, and efficacy. Next slide. So this is just an example, hospital admission levels greater than 20 per 100,000. That's going to be tipped as the red. And you'll likely hear from us if we end up in that level. You'll hear from us perhaps in medium, but certainly in high. And we're keeping good communications open with our nursing homes, assisted livings, and healthcare facilities. Next slide, please. COVID data our data hub has changed just as CDC's has changed. Now you can see at the top, it'll show hospital admission levels, and we are low throughout Rhode Island. And again, you can see wastewater, hospital admissions, the COVID diagnoses, and fatalities. So that's what it looks like now. Feel free to take a tour of it, and especially as we reach more August, September, and we are expecting a wave, that might be something that you'll be considering for your healthcare providers. Next slide, please. How do you use them? Again, medium or high probably means you'll hear from us, and there'll be some precautions that be announced for the general public and healthcare settings. And wastewater surveillance is really, we're watching trends. And again, those will give us a sense that we might be heading in towards that peak of a wave, and we would let healthcare settings know about making sure you've got beds and staff. Next slide, please. Updated infection control and prevention which was released May 11th. Next slide, just so you should know a little bit about them. Clinical guidance, staying up to date is still the guidance. Staying home in your dorm and getting tested if you have symptoms, still the guidance. Testing positive, isolate for 5 days, and then wear a mask for 10. If you're exposed, wear a mask, get tested. So this has not changed. If you've got somebody, whether, whatever the underlying condition might be, make sure they have a COVID-19 plan so they know how to get tested and how to get Paxlovid if needed. Next slide, please. By the way, IV remdesivir is available. We have a hospital at home program through Kent County Hospital where an individual who cannot take Paxlovid could get IV remdesivir. You happen to have that very unusual rare case, let us know. So again, anybody at higher risk of getting sick, we want to make sure those are the people that have a plan with you and know what their specific steps should be, should they be exposed or ill. Next slide, please. I'm going to pass this off to you, Julia.
So much. All right, just to wrap us up here, I just wanted to kind of give a glimpse into our engagement with you all moving forward. The big one being, as Dr. Bornstein had mentioned, COVID-19 is still a reportable disease, so we're still relying on your partnership in reporting outbreaks to us. So we just put this slide in here as a reference on what to send to us if you do have an outbreak. One of the changes you'll notice at the top, this email may not look as familiar. We are retiring the former IHE inbox as we're kind of consolidating our response. So please send any outbreaks to the email listed here. And in this format, as a send secure message, we'll be sure to follow up with you in support of any outbreaks. And the other thing to see at the bottom too is we no longer are asking you to send those lengthy line lists to us moving forward. So hopefully that takes some additional work off your plate. And then just looking ahead, this meeting cadence that we have with the quarterly meeting, we appreciate this platform and engagement that we've had with you all. But again, recognizing COVID-19 has kind of quieted down, it doesn't need to be the center of these meetings. We are transitioning this meeting into RIDOH's Academic Institute. So our partners there, Jennifer Ritchie, who is on the call, she and her team will be overseeing this meeting. And then, of course, if there are any COVID-19 updates, we'll be there as well to provide those for you all. But just wanted to give you the heads up that we do plan to continue with this space to engage with you from RIDOH. And then, of course, we're going to continue tracking clusters on our end. As Dr. Bornstein indicated, we will stay in communication if we are to move into any sort of high levels and support you may need. So we'll continue there. And then we'll continue with our tracking of spread severity and vaccination. And then the last thing is we're here as a resource. So any questions, general questions you may have, any outbreaks, any support you may need, we're available and happy to be there for you. So just be sure to reach out to us. You can give us a call or email us at the COVID-19 questions inbox. I think that is it for me. There are, as we said, we'll send the slides out. There are a lot of additional resources in the back for you. I won't dive into them now, but feel free to flip through those and then reach out with any questions. And before, I know we have 4 minutes, I just wanted to thank everybody again for your partnership and all your hard efforts over the last 3 years. I think we're all excited to see this transition happening and want to make sure you still feel supported moving forward. So thank you all. If there are any questions, we do have 4 minutes, so feel free to hop off the mute and we'll be here. And Jen, I see you on camera. I don't know if you wanted to quickly say hi.
Yeah, sure. Thank you. Hi, everyone. My name's Jen. I am working in our academic institute, and I currently oversee all of our research and education programs, including our internship program.
You'll be seeing more of Jen moving forward. We're excited about this space continuing, but
Yeah, definitely looking forward to it. Thank you.
any questions, comments from anybody else? This is where we might go over. Otherwise, maybe we do give back a couple minutes.
Thanks, everyone. Have a great summer.
Thanks so
You
much.
too. Thank you.
Thank you.
Bye, everyone.